just because she's amazing, Lauren's going to get 2 introductions in case you missed it last time. Dr. Lauren Bennett is our Director of Neuropsychology and Clinical Training here at Hoag. After completing her undergraduate degree at UCLA and Children's Hospital Los Angeles, she went on to get a doctorate in clinical psychology and then completed a 2-year neuropsychology postdoctoral fellowship, specializing in both sport and geriatric neuropsychology. Lauren is our superstar of all things brain here. And so when there's a patient I can't figure out what's wrong with their brain, I send them over to Lauren. Lauren, thank you for being here with us today. Looking forward to hearing you speak.
Thanks so much for having me. I'm thrilled to be here. Well, hello, everyone. I hope you're enjoying the afternoon so far. I'm sure it's been a great lineup. I'm excited to discuss today the virtual and augmented reality applications in terms of the assessment and treatment of neurocognitive disorders. So we'll dive right in. All right, so my goals today are to review a bit of what we do as neuropsychologists and then the intersection of these new technologies in terms of VR and AR and how we can augment or better support cognitive functioning, both in terms of assessment, proper diagnosis, and then treatment. All right, so what is neuropsychology? Maybe you've heard the term before, but might be a bit vague if you're anything like most folks I encounter. So essentially, it is the understanding of the brain-behavior relationship, and how we do that is by using standardized, validated measures that explore our brain tissue and the interaction then of how it's actually functioning. How do we do in terms of day-to-day life? When is it able to do what we might expect? And what patterns might emerge that might help us clarify differential diagnoses, and again, how we can strengthen someone's cognitive functioning to support their quality of life overall. The reality is the relationship between the brain and the behavior that we see in our day-to-day lives is really complex, right? And I always tease my students that I have the pleasure of working with that neuroimaging, meaning MRI and other technologies, doesn't always correspond to day-to-day functioning. That's why I still have a job, right? So I'm really fortunate in that sense. But part of the reason that I am so excited about these new technologies is they'll really deepen our understanding of in terms of the functional impact of what we may or may not see on neuroimaging. And a bit more on that here is that we can be useful in a number of different contexts in terms of neuropsychology assessments. So baseline evaluations can be useful. We'll often see this in terms of athletes, let's say, or other folks who have a high risk job. So we might do a baseline assessment of their cognitive functioning so we can measure them against themselves down the road when there might be changes in their future. We can be useful, as I mentioned, in terms of differential diagnosis. So saying, is this a Parkinson's disease presentation or more of a Lewy body presentation in terms of the cognitive signature that emerges on testing, Alzheimer's versus a vascular etiology, or even what's the severity of, let's say, a head injury? Are we tracking treatment as we might expect in terms of improvement across time? To that end, we can also be really helpful in tracking medications and other treatment impacts. So in the case of epilepsy, for example, we might do a pre-surgical workup to help inform our epilepsy team about what might be the best course of action taken together with all the other points of the evaluation to inform surgical decision-making. I had one of those calls this morning. And then, of course, again, after the surgery, so let's say that there's some sort of resection of a part of an anterior temporal lobe. What's the actual impact on that individual's day-to-day life? Are they still as robust as we're hoping after the fact? Or are we seeing more of a negative impact in terms of their visual or their verbal learning abilities? We can also track medication effects, right? So a lot of the medications that we use day to day, things like anti-epileptic drugs, they're blessings in that they can help control seizure activity, but of course they can slow down the central nervous system responses. And so we can see a negative impact there. We can also be helpful in terms of determining capacity. So can an individual make their own medical decisions? Can they financially manage their assets? Does there need to be somebody in their life who has power of attorney? When is it time to determine if it's necessary to activate that power of attorney? That's something that we can be helpful in determining or helping families navigate. And then also neurocognitive remediation or rehabilitation. So we can guide interventions. Where are the areas of weakness? Okay, perhaps somebody had a head injury and now they want to go back to school, want to tackle a new career. Where are they going to need additional supports? How effective can they be in these various occupational functionings? And where might we provide them additional resources, trainings, or other kinds of supports to make sure that they're at the highest quality of life and highest level of functioning possible? All right, so what does the Neuropsych eval actually tell us? Well, here's the thing. Most of us are really terrible judges of our own behavior, right? So most folks that sit down in my office tell me that they are a better than average driver. In fact, research would tell us that 80% of people tell us they're a better than average driver. And if you're anything like me, I hope you're scratching your head right now saying that math doesn't work out, right? And the truth is, cognition, all aspects of our cognitive functioning are a lot more complex than we originally thought. I'll use the memory drawer example. So we think about memory as one part of our cognitive functioning, but there's many things that can go awry in our memory function. So if you're anything like me, you might also have a junk drawer at home. Anyone have that junk drawer in their kitchen? Okay, so imagine you open that junk drawer and it's so full that you can't cram anything else in there, right? That might be a learning difficulty in coding new information or taking on new information. Now let's imagine you managed to shove something in that drawer, a key of importance. And then a few weeks later, you go back to look for that key. You open the drawer and it's a mess. There's things everywhere, papers flying out of you, a ton of keys, but not the one you're looking for, right? So you're searching and searching and searching. You know that information's in there, but you can't retrieve it. You can't get it out. You can't find the key, right? Now, your very helpful spouse or child comes along and they give you one of those drawer organizers and you take the time to sort it out and maybe put all the pencils in one little category or organization system, put all the keys together, and then lo and behold, the key that you're looking for pops up. That might be help from cues or structure or what we call recognition memory. Do you benefit from that additional context or support to help retrieve that information that you're looking for, right? So our evaluations can tease apart those different aspects of learning and memory to get a sense of where the difficulty truly lies and what kind of etiology or cause we might be looking at. There's lots of things, as you well know, that can impact cognition. So of course, different medical conditions, certainly our emotional bandwidth in terms of what we have available and what bandwidth we might be using in terms of our cognitive functioning to manage symptoms of depression or anxiety. Certainly medications, as we've touched on, can also impact our cognitive functioning. And then of course, if any of you had children out there, and my new parents out there, sleep, right? Sleep is non-negotiable. We've learned in the last 20 years in particular from our research. So poor sleep can really impact our cognitive bandwidth as well. So in our work together, what we try to do as we get a sense of neuropsych evals is to break apart the different parts of the brain and where there may be issues or below expectation performance. So the brain is modular, meaning there's different sections of the brain that we know are involved in different tasks. However, it's networked, right? So there's a lot of interconnections between those areas. So we can see that if you have damage to, say, a speech area of the brain, there can also be impacting other aspects of language functioning beyond just your speech because of the interconnectivity between those regions of the brain. So our goal is to basically find out the extent of the difficulties that we're seeing. We break that apart by looking at the different lobes of the brain and where we might expect to see a different etiology, cause, lesion have an impact. All right, so let's break it down a little bit more so we can get into our VR and AR utility here. So in a typical, what we call pencil and paper, that's the old school, me sitting across from you at a table and me looking at your cognitive functioning. These are the areas that I'm generally trying to assess. So what we call premorbid intellectual functioning. That's not sensitive to any change from disease or injury. Gives me a baseline of where you may have been prior to the onset of any illness. Orientation, so do you know where you are, when you are, who you are. Processing speed, how quickly you can take in information, make use of it in a meaningful way and give it back to me. Attention, meaning both your auditory and your visual attention. Memory, so as we talked about, there's both visual and verbal memory. Then our learning, in our drawer analogy, that's getting the information in. Our delayed recall, using our memory drawer analogy, that's getting the information out. And recognition, that's when I give you the organization, does it make it easier for that information to get out? All right, so if you would play along with me, I know it's been a long day, so let's do a little exercise. This is a typical way that I might assess your memory. So I will read you a list of words here: lemon, window, green, telephone. All right, now I want you to repeat that list of words back for me. Go ahead. Awesome, let's do it again. Lemon, window, green, telephone. All right, repeat that list again for me. Thank you, and one more time. Lemon, window, green, telephone. Okay, so what was that list? Can you say it back to me now? That's right. Okay. Now here's a curveball. I'm going to give you a few other words. Some were on the original list, some were not here. I'm going to read these words to you. Door, lemon, television, blue. All right, hold on to that list for me. We'll move right along. So other areas of cognitive functioning that we're assessing in our typical pencil and paper batteries are language, both expressive language and receptive language, visual spatial functioning, so things like construction, visual perception, visual organization, and then executive functioning, which are higher level, higher order tasks, things like planning, organizing, sequencing, set shifting, which is multitasking or switching back and forth between two categories of tasks, inhibition, or your ability to inhibit your first response and play by a new set of rules, and abstract reasoning. All right, so let's give you a few examples here of what we might typically use in the pencil and paper, was our current gold standard of neuropsych testing. All right, so you'll see a design on the far left of your screen that's underlined in a kind of reddish color there. Can you tell me which design, 1, 2, 3, or 4, matches the underlying design? Go ahead. You're gonna have to rotate in your brain to make it match. All right, how many of you got number 4? Awesome. Here's another example. So moving from the far left side of your screen here, there's a few overlapping figures. Holler out, what do you see in there? Did I hear fork, cup, wine bottle? Lots of you got the wine bottle. Tea kettle, bread basket or some sort of basket? Yeah. Okay, and how about our middle design? Tell me what you see. Well, it's 2 things, right? Okay, what's the bigger picture? What's the forest here? That's right, it's a man. Okay, and what are the trees? What's the more minutia detail of it? That's right, it's made of all kinds of floral and fauna. And now moving to our last design here, what do you see in terms of the large shape? It's an A, that's right. And the smaller shapes making up that large shape? E's. Awesome. So that's an example of what we call simultaneous nausea. So can you see multiple things at one time? Let's give a few examples here of executive functioning tasks we might typically use. So in terms of our inhibition, can you read those few words? But there's a trick here. Name the color of the ink that the text is printed in, and do not read the text of the word itself. Go ahead. So we've got green, red, and blue, right? So resisting that first urge to read the text of the word, which is more automatic for us, and playing by this new set of rules. And then how about an example of an abstract reasoning task? So we've got a proverb here. Can you tell me what an old ox plows a straight row means? Any ideas? Yep, absolutely. Wisdom and sage advice and input and approaches come from many years of experience, right? All right, awesome. Okay, our curveball here. Do you remember the list of words that I read to you multiple times? Can you tell me that list now? Okay, and now from this longer list of words, some of those words were on the original list, the list I read to you multiple times, and I'd like you to pick out which words were on that original list. I'll give you a moment here to do that. Okay, I think I heard a few of you, that's right. So we've got some of them were on both lists too. What was the word that was on both lists, the first list and the second list? That's right, lemon. Awesome, okay. So now let's talk about the intersection of how VR and AR can really enhance what we're currently doing. So obviously, in terms of this type of test data that we just went through, after I finish my assessment, I go back to my office, I have to hand score everything up, and then I have to compare that testing data to other folks in the same age, education, and gender, right? That takes a lot of time, an enormous amount of time, as you can imagine. The other thing is I, as a human, am not that precise, right? So some of my measures are timed, but they're not timed to the millisecond, just as fast as I can operate my timer. But with VR and AR, we have precision of the data, right? We can also get a dynamic assessment. So it responds to how the individual is doing in the moment. If they're doing well, it can get more challenging. If they're not doing as well in an area, it can go backwards in terms of establishing a basal or a baseline in this area of functioning. We also have digital biomarkers, which has come up a few times today. But we can also track things in our context like eye movements, for example. Are they spending time on a particular area of an image? How long are they spending on non-identified target stimuli? Are they looking at the wrong area for 30 seconds or 3 seconds? All of those different pieces we can also track with some of these new technologies. And then of course the speed of the data, right? So I have this data back to me, that how they're doing in their cognitive profile, so I can analyze that right in the moment and perhaps even have a discussion with the patient and their family before they leave my office, right? So it's real-time data that I can then integrate into making a comprehensive assessment. Of course, VR and AR technologies are going to be way more adaptable in terms of language and cultural needs, right? So I might be able to adapt my test readily to reflect the culture that that individual grew up in. So if I'm asking somebody to name particular objects, I'm showing them an object and they have to tell me the name of it, I can adapt that to the culture that they grew up in to make sure that it's culturally appropriate in that sense. But essentially, VR and AR can allow me to not only detect impairments in the moment, but follow the course of a disease process across time and monitor response to treatment. So there have been numerous studies out there that have highlighted the sensitivity of these measures, the feasibility, and the utility of using these types of assessments. The other really wonderful thing about VR and AR that you might expect is the ecological validity, right? So they mimic everyday tasks and conditions that are more sensitive than my pencil and paper test. So I often hear from my patients, why in the world are you making me do this connect the dot, right? Of course, that would be frustrating if I was them too. So if I try to explain that this connect the dot is actually going to give me a good prediction in terms of their driving success, that can be really frustrating for patients. And of course, it's not always the most accurate, but it's one of the best tools we have available. But with the advent of VR and AR assessment, I can put them in a driving simulator. I can see how they can actually do in risky situations, risky meaning in the context of a virtual reality world. And I can see how they respond to a ball rolling out in front of them, or a car swerving into their lane, or an unpredictable construction pattern that takes them off their set route. So I can see how they do in navigating a new city or a new pathway, right? I can take them out of their current environment where they're comfortable and routine and see how they do in the midst of some of this confusion. This allows me an immensely safe and standardized setting where I can exert specific control over the context of the experiment and then really measure the skill or the set of skills that I'm looking to assess in this context. Of course, there's also a huge benefit in terms of engagement and motivation. So would you rather do the connect the dot or play a video game, right? So we can make it fun and engaging. We can make these tasks really speak to these individuals in terms of VR and AR naturally pull for the individual to get engaged. They're designed to help them want to move around the environment or use a joystick, for example, to interact with the things around them. We also have increased flexibility about when and where and with whom these assessments can be conducted. That can also support the engagement and motivation, right? I don't have to necessarily drive to my nearest city center, which might be hours away to do this. I might be able to do this in my local treatment center and then also have a conversation via telehealth with a provider who's an expert in this area who might be, 3 hours away in Atlanta or wherever. All right, so in terms of the need and what we see here, I just wanted to highlight some of the numbers from Orange County. The number I want to point out here is the green dotted line. So that's our 65 plus community and the projection of growth in that population. This slide comes to me from my dear colleague, Junko Harris, so thanks to her for letting me borrow it. And what we see is that there's going to be an enormous growth in this population, not just in Orange County, but really across the country. So the reality is what we call the silver tsunami is coming, and we need to be ready to assess it. As we touched on, there's digital biomarkers that are innate within these types of setups that can give us a multitude and cornucopia of different data and stimulus feedback in real time to get a more sensitive diagnosis. So what I want to touch on here is that this will be innate within our life, hopefully, as we continue to see more and more of the phenomenal technologies that we've heard about today come on time in terms of prime time accessibility and real life application. So things like changes in mobility, physical activity, sleep patterns, how we're typing on our devices, speech fluency, right? So does your Alexa detect now that you have a bit of dysarthria in terms of your speech pattern, Could that then ping my treatment providers to say that I might need an assessment to see if there's an emerging synucleopathy, like a movement disorder of Parkinson's or Lewy body? Am I interacting with my apps more slowly? Is it taking me more time to navigate them? Does that show that I'm having some motoric slowing? All of these data points can then be aggregated to help really meaningfully inform treatment. And with these large algorithms, they can detect, hopefully in the future, really small details that we wouldn't necessarily pick up until years into the disease process. So having these really subtle hints at the earliest outset would be really meaningful data. I'll underscore just a few pieces of our utility here. So the use of digital biomarkers across these different settings is also really helpful in the movement towards precision neurology. It's ipsilateral, meaning I'm comparing myself to myself, right? That's the best kind of data we have when we have a baseline for someone. And it's ongoing. So it's not just one day a year, right? Or one day every few years. They're cost effective because they're implanted within our day-to-day life and technologies we're already used. And then there's hundreds of different data points, even thousands, that can again be aggregated to detect meaningful change. So specifically, as we look at the world of neurodegenerative disorders, this is a really viable method. And there have been multiple studies that have explored the utility of this technology with older adults, and specifically folks with Alzheimer's disease. We see the strongest benefits in terms of the outcome of this data and analyses when they use the same theoretical models that underpin those pencil and paper testing that I went through with you earlier. When we're able to take that and apply it to a digital and virtual reality, we see that they're quite successful in terms of detecting actual meaningful changes in regional brain volumes that are significant for diagnosis, like the degeneration of the hippocampus. I'll quickly just highlight here that there's really interesting, unique utility of VR and AR. They let us look at things that we couldn't do in our pencil and paper testing. The example I'll use here is allocentric, meaning world-centered perspective, versus egocentric, meaning me perspective. So I can test somebody's knowledge of kind of a bird's eye map or virtual park, for example, versus my ability to be navigating a specific route or path like a virtual maze. That's testing I couldn't do in pencil and paper, but I have the utility to do through virtual reality applications. So as we touched on maps and mazes, I also can get a really detailed breakdown of how somebody will realistically do in terms of their activities of daily living. We get a functional assessment. Then, of course, use the same types of games and puzzles that I use in my day-to-day assessments currently. So with the time I have left, I'll just breeze through a few of these. I want you to spot the differences. So here I'd ask you to look at the countertop, specifically pay attention to what's on the counter. All right, tell me what's different here. Okay, hopefully you found a few. That's right, we've got 3 different things that popped out. We'll try one more here. So I'm going to do another round of this. What do you see? What's different between that past image? I'll show you once more. And this second image. All right, and if they're side by side, I'm sure a few folks got it here. That's right, so there's 6 different differences all circled out. All right. And I'll just end by highlighting that what we're looking at is actually our visual attention, our processing speed, our eye movement tracking, and I'll give you one more example that we'll end with. Here is a very commonly used day-to-day neuropsych testing that we have to make this shape, but you're starting from this position. So I want you to imagine in virtual reality that then the individual could interact with this data. We not only get a sense of their visual spatial reasoning ability, their sequencing and planning in terms of their executive functioning, but we also might get some data on their fine motor functioning by assessing their pincer grasp, right? We can also track their eye movements, their time, very specifically in terms of the biomarkers that we're able to do. And I'll end here. This is our best example in terms of ADLs, or activities of daily living. We actually have tests that walk through in about 15 minutes time, somebody doing all of this morning routine, going to a grocery store after their morning routine, using currency to pay for different items and find different items in a grocery store, Obviously, this kind of richness of data is going to give me far more detail than I might ever get in terms of the tasks I can mimic in a lab or a testing environment. So I'll get really, really nuanced information about how someone can navigate their day-to-day life that allows me as the clinician to make a far more informed decision. Okay, I'll leave it there for today and turn it over back for Q&A.
Awesome. Thank you so much, Lauren. Appreciate your talk. Do we have any questions for Lauren, Dr. Bennett? This is, to me, one of the most exciting areas of development that we've got going on right now, because the combination of the sensor technology, which Charles was speaking about earlier, and the increasing sophistication of the software to match, this is where we really have an opportunity to kind of, not just do the assessments, but also do some remediation as well. I think it's a fantastic opportunity.
Great.
Thanks, Lauren.
My pleasure. Thanks for having me.
Take care.